So we are the West's best wonks. So this is my team. I'm Karam from UC, Alex from
Cal State LA.
Exactly. Ben.
From Party Rand Graduate School.
And Joanna.
From UC Denver.
And Joanna will start.
Oh.
Thank you. So originally, we started off with a very optimistic point of view, and we included a lot of initiatives that we personally believed would yield a lot of benefit, including pathways for families, hospice care, and also post-discharge care. And in terms of financing strategies, we only included contingent global payment, and we wanted to focus on some funding options that would improve care overall. And so basically, we had really big dreams and really expansive goals, and we didn't have enough money to fulfill them. And you can see that here in the results of our initial model run. This is a very poor score, and we realized that the reason that we were getting this result is because we ran out of money. We absolutely could not sustain the great initiatives that we were putting in place.
So to expand on what Johanna was talking about, when we went into this, we focused on two things that we heard repeatedly and read in the case study. One was that the population had about 30% below the poverty line, severely below, I believe. Also a rapidly aging population. So as she talked about, we were focused on things that were really addressing poverty as well as care for elderly. But we had to shift dramatically after running the first scenario. We reconfigured our program package to drop family pathways, to drop hospice and post-discharge. We added reinvestment. When we added reinvestment, we suddenly saw that we could afford what we were doing. In fact, we started to run a surplus, which was nice. We also added environmental considerations and added the student pathways. I don't know why, but for us, the student pathways worked better. And we had kind of had a theory that maybe it was because students that were successful in graduating and so forth could overall affect the better, or could make the economy and community better in the long term. So this was our final package. It's sort of self-explanatory, but you'll see we enabled healthy behaviors. We basically fully funded, especially the risk factors, the reduced environmental hazards. For whatever reason, we started it a year or two later. That worked for us. I'm not sure why. We had support self-care and coordinated care, and then we had contingent global payment and reinvestment savings at 100%. And that was the score that we got. We've tinkered with it quite a bit, and a lot of times our theories didn't match up with what the score was giving us. One of the things that we found kind of confusing was that we kept worrying about shortfalls. However, shortfalls didn't necessarily negatively affect our score here. So we'll go to the next slide. Okay, here's an overview of the key indicators. One of the things that was really nice was that when we came up with our final package, it was pretty evenly scored across the different success factors that we were looking at. One of the challenges we had early on when we were doing all the great things Johanna was talking about was that we saw we had this huge benefit in inequality, but we were lacking in mortality and other sort of health-related factors. And when we went back and changed it so that we were doing less with the family pathway, and we were focusing, well, we added in the reinvestment, which helped our bottom line, the affordability of our program, everything evened out. But there are trade-offs. So if you look at this, this is also sort of a discussion of our pitfalls. If you looked at the pitfalls in our task 2 analysis, the one that really jumped out was the specialist average income, which is over here. It's this one. It's far below the baseline, and that was the primary area of focus from the simulator. But when we dug around more, we also found this one, which was, I forget, what was that called? It was the unmet need?
Yeah, unmet.
Yeah, unmet needs. And so we found in 2020, we had this huge spike in demand that we couldn't accommodate. The other thing we found was when we were looking at the stakeholders, there was this huge drop in hospital operating margins, And we had this theory that those two things were tied together. So stakeholder reactions, largely because of the way we approached it, social workers, nurses, the commissioner, they all loved the program. However, our biggest problem with the hospital and Dr. Doctor. Dr. Doctor was unhappy because the specialists were not salaries that they expected. And we had this feeling that that was going to be something that would be very challenging to address when we got to task 3. But the biggest problem was the hospital. Even though it was odd, it didn't show up as a pitfall, but there was a 300% drop within about 25 years of their operating margin, which we knew wasn't going to be acceptable.
So in response to sort of these stakeholder concerns, we made a number of changes to the package that resulted from task number 2. We have sort of them outlined here. Number one, and this is probably one of the biggest changes, is that we dropped student pathways. And student pathways gave us a lot of return, significant return in terms of productivity, but it wasn't, when we compared it to some other alternatives that were out there, it just wasn't competitive with those. So, and we also had, like we pointed out in those charts, that huge unmet need, that capacity that we just did not have. We were pushing all these people into sort of primary care, and we didn't have the primary care clinicians there to serve them. So we really needed to put that in. So we dropped student pathways and we added PCP recruitment. We went for generally, not just the, what was it called? The FCHQ, because we wanted to sort of like generally for all the population. It wasn't clear who was really driving that unmet demand. So we just generally looked for more primary care providers. So another initiative that we changed was the contingent global payment. Originally we had just maxed it out at 100% coverage for everything. Then we sort of thought about it and decided that we could sort of reduce the coverage for the commercial insurance policies because they can sort of pay without that protection of the CGP that the CGP provides. They can sort of provide the care to their customers. We also changed the reinvestment of savings. Originally, again, we had it maxed out at 100%. We figured that we could get more buy-in across stakeholders, including hospitals, which were losing out so far in our package, by allowing them to sort of allocate their costs the way they wanted, and they didn't have to reinvest in these things every year. So these are some of the impacts that we found. Sort of the first 4 are kind of interesting to the medical society, to steal a term from another team. These are, you can see that with task 2, we actually had higher reductions in per capita costs, per capita healthcare costs, higher reductions in death and better health status overall. But by changing it, we sort of reduced those things. But the real impact that we see is in these bottom 3. Where the unmet need, originally that big bump that we saw, that was an 800% increase in the demand for primary care. And that's just not something we can just allow to just go by. A lot of those people were actually being funneled into ER that we actually found from another chart. We didn't include it here, but they were being funneled into ER. And so with the change, we dropped that to 100% increase, which is still, an increase, but it's much more, something that you could probably get buy-in from the stakeholders a lot more easily. Hospital operating margins, similarly, we had a 300% decrease in their margins, their profitability margins. And after the changes, we dropped that to a 32% decrease, which is a lot closer to baseline and a lot more easy to sort of get the doctors and the hairy hospitals on board. The specialist income, we were trying our best to get that closer to baseline. We did go from a 15 to a 13% decrease, and afterwards that sort of disappeared. That was one of our pitfalls, and after we did that decrease, the pitfall sort of disappeared, so we took that as meaning maybe specialists would be a little bit more on board with our package. And so, going back to that slide, you sort of look at the impact, that little gap that we found, that unmet need, and now you see in the pink, that's our new package in task 3. And you can see the drop from 800 to 100% increase. And hospital operating margins, that's a huge difference. Like they're losing out 300%, and now they're a lot closer to the baseline. And so they could probably be more behind this package now, just seeing that chart. So some of the trade-offs that we sort of encountered in all these, in devising all these solutions was that by improving care and reducing illness, you basically lead to a drop in profitability for specialists, for primary care providers, for hospitals. And that's something that you need to take into account. It also leads to a surge in demand for primary care visits. If people are getting the primary care that they might need, that's a huge surge in demand, and you need the capacity to sort of meet that need. Also, and when we were considering the stakeholders, very useful exercise because we got to consider some of the other perspectives that we may not have considered, even with the 4 different backgrounds that we have. It's something that the simulator allowed us to sort of get at that we might not have gotten to otherwise. So we considered the hospital and provider stakeholders because they needed to buy in, because you don't want them opposing every step of the way. Payment reform also needs to be sort of tweaked, and we wish we had more time to tweak it a little bit better, because I'm sure we could have achieved better scores or better outcomes just by tweaking payment a little bit. But when you put in these payment reforms, it's clear that you have to sort of balance the needs of the community and balance the needs of providers and things like that.
I think, I would just add, and like everybody else, the presentation was put together very quickly, so a couple of things we missed. In the initial proposal in task 2, we were running a surplus. But when we made these changes that looked good as far as all the other charts go, again, we had this pretty big shortfall. And oddly, it just didn't show up as a pitfall or any of these other things, but it existed. And we weren't sure exactly how to deal with that, but it's there, yeah.
So the lessons learned, actually we learned a lot. These are just a very few of them. So first of all, we need to think of this infrastructure instead of the program itself. I mean, infrastructure is more important. And innovation funds were good, but we needed something to help us with funding in the long term. And we had increased the healthy behavior, but we haven't thought of the capacity building, so that's what we added to the second scenario. The stakeholders are very important, like hospitals and specialists. Definitely, they're very important because we don't want them to lose their job and leave the community. But actually, the most important person to think of is the community and actually the healthcare system that is providing that services. And the other thing that was important for me was, I mean, not for me, for all of us, but it might be not very much here, was the balance of the demand, supply and demand, and of course the balance of all of these criteria, because we had like more than 50 for all of these criteria. So we had actually a very good balance. But you had something else for balance of ambitiousness.
Yeah, I mean, we sort of covered it. I know we're kind of blowing past the time, but basically what we came to the conclusion is, we had all these big ambitious goals, and the simulation sort of tempered those with reality. And so we had to face the realities of what our interventions were doing to the market and sort of adjust our strategies accordingly.
All right, thank you very much. Very interesting. Thank you. I appreciate that. And I know all the rest of you went through this and came up with some good results as well. But it's congratulations on winning the competition and giving such a fine presentation. Thank you all. Thanks a lot. Thank you. I also want to, again, thank all of you for coming. It's just great to have you here at the Price School and participate in this NASPAA event. I'm hoping that this is going to be the first of many years of competitions that future students will participate in. And we really would appreciate your feedback, how to improve the process, how you interacted with it, what we can do to help make this better. We're hoping that this will become the major national student case competition, and we hope to bring this global because NASPAA is also a global organization. you know, in the next few years. So thank you again, and please have a safe trip back home. And we hope that this also will help you in the future when you're actually implementing healthcare in your communities. Thank you all.